So I'm going to talk today about ketamine in total intravenous anesthesia. So what I'm going to talk about is the benefits, the challenges, and if I've got time, I'll go a bit into the dosing protocols for ketamine in total intravenous anesthesia. So we all know ketamine is a dissociative anesthetic with very unique properties that makes it a very valuable adjunct or a primary agent in total intravenous anesthesia. As we all know, ketamine acts primarily on the NMDA receptor antagonist, but it also interacts with the opioid, the monoaminergic, and the cholinergic receptors. When you give it intravenously, it has got a very rapid onset of action. And if we give a single bolus dose, it lasts for about 10 to 15 minutes. But the action can last longer if you run it as an infusion. It is metabolized in the hepatic with active metabolite known as norketamine. Why do we use ketamine in TIVA? Because of its good analgesic properties. It's hemodynamically stable, can cause bronchodilation, which is good in asthmatic patients. It prevents opiate-induced hyperalgesia, and it can create a bit of amnesia and dissociation. So what are the common dosings we use in TIVA? For an induction dose, the dosage is usually 0.5 to 2 milligrams per kg as a bolus dose. And then you maintain with 0.2 to 0.5 milligrams per kg per hour. But if you go on to cases doing trauma or burns, you will need a higher dose to get the analgesic properties well into place. If you are using purely for analgesia, especially like in cases like burns where you need to give some form of pain relief post-operatively, a dose of 0.1 to 0.5 milligrams per kg per hour will be sufficient. Hemodynamic stability, the sympathomimetic effects of heart rate rising and the blood pressure going up makes ketamine a very useful agent, especially in hypertensive patients or in trauma patients. Ketamine will not cause hypotension or bradycardia as what propofol or remifentanil, especially remifentanil, can cause severe bradycardia. It provides a very potent analgesia at sub-anesthetic doses, and which will help to reduce the need for opiates. So there's less risk of opiate-induced hyperalgesia or respiratory depression. The beauty of using ketamine as an analgesic is you can use it as a multimodal pain relief as such. Combining with a low dose of opiate, low dose of ketamine, you get very good pain relief. It prevents central sensitization by acting on the NMDA receptor. The antagonism helps to reduce the development of a chronic post-operative or neuropathic pain. As I mentioned earlier, ketamine causes bronchodilation, and it's especially useful in patients who have got a history of asthma or COPD. At sub-anesthetic doses, ketamine will maintain the spontaneous breathing of a patient. It's very useful in procedural sedation outside the operating room. I tend to use ketamine in my center where we do upper scopes, OGDS or colonoscopes in children in the endoscopy suites. So I use a lot of ketamine as an infusion in these kits. There is some evidence, the literature, about neuroprotection in ischemic conditions, but this data is mixed. As I mentioned, at sub-anesthetic doses, ketamine will preserve the spontaneous ventilation of a patient. So it is very advantageous in certain sedation protocols outside the operating room, right? Especially like I mentioned in the endoscopy suites, patients going, especially children going for MRI or CT scans. So it is very useful in those scenarios. So what are the challenges and the limitations we have when we use ketamine in TIVA? As we all know, ketamine will cause vivid dreams, hallucinations, or even deliriums during recovery. This is seen more in adults, but we can overcome this by pre-medicating our patients with some form of benzodiazepines like diazepam or midazolam. Ketamine will increase secretions because it stimulates the salivary and the tracheobronchial secretions to increase. So you might need to use an anticholinergic in your pre-medication, preferably like glycopyrrolate. It can produce dysphoria or disorientation even at sub-anesthetic doses. So this is a challenge we have to face. As we all know, ketamine can cause rise in the intracranial pressure or intraocular pressure. Because of the longer contact-sensitive half-life compared to agents like propofol or remifentanil, there can be a delayed recovery from ketamine, and this will prolong the emergence, especially when you're doing repeated dosing of ketamine. Now, ketamine alone, we can't use it purely as a TIVA. We need a combination with propofol, opiates, or even dexmedetomidine. But in children, I've used purely ketamine, and it really seems to work, especially in the endoscopy suites. So there is so far no proper TCI model for ketamine. So you have to calculate and do it as a manual titration. So I'm going on to some of the protocols which is available, especially in short procedures like burns dressing or trauma, like doing a CMR manipulation for a fracture. You just induce the patients with 1 to 2 milligrams per kg of ketamine, and then you maintain with 0.5 to 2 milligrams per kg per hour as an infusion. You can add in some adjuncts like midazolam or glycopyrrolate to cause a bit of amnesia as well as decrease the secretions. Now, you can use ketamine as a primary agent where you induce with 1 to 2 milligrams per kg IV bolus, but you maintain with 0.5 to 2 milligrams per kg per hour. You use a lower end, that means the 1 milligram for you just want slight sedation, or you go to the higher dosage if you want a full anesthesia. I mentioned midazolam and glycopyrrolate will need to be added in as adjuncts to control sedation as well as secretions. Second protocol is something we call Ketofol, where ketamine is mixed with propofol. The goal here is to create a hemodynamic stability with sedation. As we all know, propofol will cause a drop in blood pressure. Ketamine causes a rise in blood pressure. And so that counteracts the blood pressure, that causes the hemodynamic stability for the patient. And the propofol will give the sedation part. Usually the mixture is 1:1. I usually mix 10 milligrams of ketamine to 10 milligrams of propofol. And then we start at 0.5 to 1 milligram per kg of this mixture. And then we maintain at 50 to 100 mics per kg per minute. So the benefit of this is it reduces the respiratory depression as well as the blood pressure drop caused by propofol. Ketofol, the goal is to get a balanced sedation, good analgesia with hemodynamic stability. Like I mentioned, mixture is 1:1, and this is the dosings. So the advantage of mixing ketamine with propofol, it will reduce the dose of each drug which we need, causes less respiratory depression, and maintains a good blood pressure. The third protocol is a combination of ketamine, propofol, and remifentanil, useful in major surgeries or patients who are very opioid tolerant. So we induce the patients with a propofol of 1.5 to 2 milligrams per kg body weight, ketamine with 0.5 to 1 milligram per kg body weight, and we start an infusion of remifentanil of 0.5 to 1 mic per kg. And then we just maintain propofol at about 50 mics per kg per minute, ketamine running at 0.25 to 0.5, and remifentanil at 0.05 to 0.2. So when you're doing this, basically you need 3 syringe pumps. You don't try mix ketamine and propofol and try and run it together as in one syringe. It's not very safe. It's safer to have each in a separate syringe running at a separate dosage level. The fourth protocol is using ketamine with dexmedetomidine. It's useful for sedation, especially in a spontaneous breathing patient. You load the patient with dexmedetomidine of 0.5 to 1 mic per kg over a period of 10 minutes. Then you maintain it with 0.2 to 0.7 mics per kg per hour. Ketamine, you give a bolus of 0.25 or to 0.5, and then you maintain it 0.2 to 1 milligram per kg per hour. Now, I tend to use ketamine and dex, especially in the ICU settings, when I am actually coming out from a ventilation, weaning the patient off a ventilator. Low-dose ketamine, like I mentioned earlier, especially in burns patient post-operatively, can use it as part of a multimodal analgesia, especially in propofol-based TIVA, where you give a bolus of 0.25 to 0.5, and then you maintain with 0.1 to 0.5 milligrams per kg. So in this case, you reduce the use of opiates as well as propofol, and it prevents opioid-induced hyperalgesia. So what are the practical tips when you use ketamine in TIVA? The most important thing is you need to titrate to get the effect on the patient. So you need to monitor depth, especially when we use our sevoflurane or isoflurane gases. We have got the MAC to guide us the depth of anesthesia. When you use TIVA, you need to monitor the depth of anesthesia, either using base or entropy or something. You need to monitor, because medico-legally, you might think the patient is asleep, but patient can be aware if you do not monitor the depth of anesthesia. You need to use some form of anticholinergics, especially like best is glycopyrrolate, to control the secretions caused by ketamine. Benzodiazepines can be used to prevent the emergence delirium. Give a small dose. You can give it as a pre-medication, or you can give it just at the start of surgery as an induction. Patients who are elderly, renal or hepatic impairment, we need to adjust the doses accordingly to anesthetize this group of people. You need to monitor the hemodynamics and the respiratory status, especially if the patient is breathing spontaneously. So, when you use ketamine in a balanced TIVA strategy, the propofol provides the hypnosis and sedation. Your ketamine is adding analgesia and maintains a sympathetic tone and the NMDA blockade. The Dex will help with the sedation and analgesia and reduce the emergent reactions. Remifentanil, as we all know, it's a very potent but a very short-acting analgesic. It's very ideal for intraoperative pain control. Coming to remifentanil, I sometimes use remifentanil as a low-dose TCI infusion in patients post-operatively to continue with the pain management. So where I combine remifentanil with ketamine as a low-dose infusion in a multimodal analgesic pattern. So this will cause a reduce in the opiate use, improves the stability of the patient, and has a better recovery profile. Thank you very much.